cancer. It includes the removal of tissue that we know can develop into cancer before it progresses at all. A common example is carcinoma of the colon. There are polyps in the colon, and these polyps, by virtue of their behavior, some of them can change and become cancer. What the chairman mentioned, colonoscopy, is what is recommended to be done at a certain stage, the age of 50 if I'm not mistaken, and that should be regular screening colonoscopy. But because many centers do not have that, and many people are not enlightened about the need for colonoscopy, we do not see these lesions. We've had at least 2 American presidents who have had their colonoscopy while in office. If I'm not mistaken, one of them had polyps.
What kind of example?
One of the American presidents, sitting American president at that time, had polyps that were suspicious removed, and that precluded the development of cancer. Next slide, please. So this next slide shows some of the polyps in the colon. Some are innocuous, some are so benign that they don't cause any problem, but some can. How would you know which one? It is best to see an expert, and at colonoscopy they will decide if they remove the polyp and they send it for histology. Next slide, please. Another example, which is one of the cancers that ravages women in developing countries and still causes, is one of the causes, preventable actually. This is a cancer that is really in quote completely preventable, because not only has it been reduced significantly in developed countries, there is a vaccine that can help in the prevention of human papillomavirus infection, which is one of those that is implicated in development of cancer of the cervix. Now, even if we miss it at that stage, that we don't give the vaccination to girls before pre-exposure to sexual intercourse, if you don't give them the vaccine, I think it's 2 doses. I am aware one of my colleagues, Dr. Lawal, working with an NGO, is trying to advocate that the government should make HPV vaccine free for all girls. I hope one day we can have that, and that will make us remove cancer of the cervix from the dictionary in Nigeria. So if there is what we call a cervical intraepithelial neoplasia, that is a stage in which you see abnormal cells in the cervix. By the way, I'm sorry, the cervix is part of the uterus, the womb. It is the furthermost part. That's the part that is very close to the birth canal, that it looks like the tip of a nose when touched from below. So this cervix is what dilates, what expands, so that baby can come out during childbirth. So it can become cancerous, or it can first manifest with some abnormal atypical cells, and that can be treated, and this cancer will not develop in that patient. Next slide, please. Now this slide shows 2 treatments for cervical intraepithelial neoplasia. It can be laser treatment, and it can be cold knife, what we call cryotherapy, and that is available in a couple of centers in Nigeria. The others still use open surgery and sometimes do hysterectomy, which is removal of the womb as well as the cervix to ensure that that doesn't develop. Next slide. Now this is Angelina Jolie. I'm sure some of us in the audience will know her. She's a popular Hollywood actress who had parents, the mother had carcinoma of the ovary. Now, she also had breast cancer gene mutation. So when the BRCA1 and BRCA2 genes they can be detected, whether there are mutations in them, can be detected in some centers already in Nigeria. Now, if she had a mutation in the breast cancer gene, and that means that at a stage in life, there is a very high likelihood that she will have breast cancer or ovarian cancer. So she had the breast removed. She had the double mastectomy, and then after a couple of years or so, she also had ovaries removed. Now, that led to some debate as to the advantage or not of that. It certainly reduces the risk, but I'll talk about that risk in a jiffy. Next slide, please. Another popular person, the former First Lady Nancy Reagan, also had mastectomy. Now, she had mastectomy following a breast lump excision. Now, the breast lump excision she had, she could have had what we call breast conserving surgery, but she decided to have a mastectomy at that point in time, and that made mastectomy less scary to American women. In fact, there was an improvement in acceptability of mastectomy, that's surgical removal of the breast, following what Nancy Reagan underwent. Next slide, please. Now, in these prophylactic surgeries, it doesn't completely remove the risk of the development of breast cancer. We must be clear of that. That even in someone who has removed the ovaries alone, of course, removal of the ovaries means the woman will become menopausal. It will accelerate menopause, and menopause has issues that are associated with it as well. So there's a 50% reduction in breast cancer risk, but there's a 50% risk at the other end. Now, if both breasts and ovaries are removed in someone who has a breast cancer gene mutation, now I didn't say a normal individual, no. It's someone who has a breast cancer gene mutation. There is a 90% reduction in breast cancer risk, which is quite good. But on the other side, we still have a 10% risk. So in other words, it doesn't mean the individual will still go to sleep. There will still be what is called annual or regular checkups that need to be done. Next slide, please. This I'll mention just in passing, staging surgery, because we don't use this frequently nowadays. It used to be common with lymphomas, that's blood tissue or lymphatic tissue cancers, or bloody cancers of leukemia, especially the chronic type. Now, we don't use that because we have investigations that can show us what we intend to do by doing staging surgery. Nowadays, we have to do that. We intend to use the minimally invasive approach. We can do laparoscopy and so on. Next slide, please. Next, I'm going to talk about debulking surgery. Debulking surgery is surgical removal of as much of the cancer tissue as feasible, as safe. I tell people that surgery can be done, you can remove anything, really, but how safe is your surgery? That is what limits us. There's no point removing everything. You say there's cancer of the lungs and it's spread, it's now very touching on the major pipe, the aorta, carrying blood from the heart. You now want to remove the lung, remove the aorta, and you can remove the heart, and then there's no patient left. So what surgery means when we talk about removal is safe. We want to remove much of the tissue of interest, but that the patient must be alive at the end of the operation. So in debulking surgery, it's when we see that it's not safe technically to remove the tissue completely without causing more problem. So we remove as much as possible and leave the ones that are sometimes involving major vessels or nerves, and then we go ahead with chemotherapy and or radiation therapy. Sometimes the bulking surgery is done to reduce the severity of pain or obstruction that is causing difficulty in passing stool that the patient has. Next slide, please. Another role for surgery is restorative surgery, and that is getting increasingly used in Nigeria, because cancer does not mean that we treat the patient and then cast the patient off aside and that the patient should not integrate into the body. People have gone on to have normal lives after they've had cancer surgery, because you can recreate body part or what is similar to that body part. Sometimes you combine it with the primary surgery, that's the first surgery in removing the cancer cells. Sometimes we do it in stages at the later time. There are pros and cons of either process, and sometimes we use the tissue of the individual in what we call flap. For instance, in removing the breast, we can raise a flap, that's raise some part of the muscle of the abdominal wall that covers the abdomen, and move them up and recreate them to be like the breast. Next slide, please. So this is shown in this slide. These are some those are some reconstructive surgeries after breast surgery in women. And then the first picture on the far on the left of your screen, you will see that the patient had right breast cancer, and that was removed, and at the same time there was a reconstruction, and you can hardly see the difference between the two breasts. There are various adjuncts. Sometimes we use breast implants, sometimes we raise flap. Next slide. And there are now multiple options based on the expertise of the surgeon. This is usually a form of collaboration between the general surgeon, the plastic surgeon, and working sometimes with the oncologist. Next slide, please. Next, I talk about supportive surgery. This is what surgery does to help in other treatments as an adjunct, or to ensure that other things are possible for the patient. Next slide, please. One of the first I'll mention here is the insertion of a port catheter system, and this is not routinely done in Nigeria, but we need to at one point or the other start doing this. These are port catheters that we can implant into the pectoralis muscle, and it is hidden under the skin. It's for a patient who will have chemotherapy for months, so we can then insert a needle through the skin into that soft part, usually a soft part of that device, and that can be done. So it avoids the need to keep pricking. You know, when patients come for chemotherapy, one of the most challenging things is that after the first chemotherapy sessions, the subsequent ones it's really difficult to get to find the veins, and you know, we even don't have the anesthetic creams, the EMLA creams, so getting venous access is often traumatic in our patients. And sometimes, because I am a pediatric surgeon, I treat children who have cancers, and sometimes I want to cry myself, because when the child is crying, they are trying to find venous access, because you have given, when you give chemo into the vein, the veins become thrombosed, and then you find it difficult to get other veins. Now, insertion of the pump will avoid all that pain or that emotional turmoil in both the patient and the surgeon and the oncologist as well. Next slide, please. Now we go to, I think this is one of the very last set of treatments by surgery. Next slide, please. Here, the role of laparoscopy. Laparoscopy is becoming increasingly popular, and at Obafemi Awolowo University, at the University College Hospital, UCH, at Lagos University Teaching Hospital, and I think at LASU, I think at a few other centers, we can have laparoscopy done, and we can view the abdomen. In fact, Zaria as well. I have colleagues in Kano, so you can see that this is becoming widespread. In fact, I just came from National Hospital Abuja, and they have a beautiful set as well in their center, both for pediatrics, both for children and for adults. So you can look at the internal organ to see if there is an abnormal organ. Maybe an ultrasound pick something, or a CT scan pick something. You can do laparoscopy sometimes as a diagnostic tool when the need arises. Right? It can also help us to look at the extent of disease. Next slide, please. This is one of the uses of laparoscopy. This here is Professor Kingsley Ekweme, who was my colleague from, also an alumnus of the University of Ibadan, who was doing one of the first sets of prostatectomy at one of our private hospitals in Lagos, Nigeria, and that can actually revolutionize the care of patients with prostate cancer. Next slide. I know that we already have transurethral resection of the prostate, which is done for benign prostatic enlargement. So this laparoscopic radical prostatectomy is helpful because it avoids some of the complications that can arise when the surgery is done using the open approach. But we need to have more of these done in centers across Nigeria so that the men will be less scared of erectile dysfunction, which is worrisome. One of the things that make the men run away is that they don't want to be impotent. But then the other side is that this is prostate cancer. But men like their virility so much. So these are things that we need to work around so that we can encourage our men to seek care and let the surgery be done while it is still possible to achieve care. Next slide. Now we have moved to robotic surgery, which is an advancement from laparoscopic surgery, but that is not available yet locally. We hope that in the next few years or next few months, perhaps we're going to have one or two centers start robotic surgery. Next slide, please. We also have laser treatment. I know that laser treatment that we tend to hear about are the ones that are cosmetic. Talks about there's a Dr. Laser who is one of these Hollywood doctors. I know it's done for cosmetic surgery. Laser surgery or laser treatment is also useful for treatment of cancer. Prostate cancer, skin cancers can be treated using laser. Next slide. Cryosurgery, which is using cold, that's temperature, where we use liquid nitrogen to cause a severe temperature drop in a tissue that desiccates it and causes it to die off, and that tissue falls off, and that is useful in the care of skin cancers. As you see, even in Africa, in Uganda, that is available. Now, I think the last set of treatment, next slide, is metastatectomy. Don't mind the jaw breaking word. It just means the surgical removal of metastatic cancer. For instance, if a woman has breast cancer that spreads to the liver, and you know that there's only one metastasis or one lobe of the liver is involved. If the patient has had undergone primary surgery and everything is clear except that liver. It can reset the lobe of the liver. That is already done. One of my colleagues who trained at Memorial Slow Catering does that at the University College Hospital in Ibadan. And I know that it's also done in liver. So you can go after the metastatic cancer provided the primary disease is well controlled. And this helps to improve the chances of survival. Of course, it is not only surgical, it's also followed with other types of treatment. Next slide, please. This shows the possibility of metastaectomy that we can also use to treat spinal metastasis. Next slide. In view of time, I will move to the next slide. Okay, yes, there's this paper from the IFE and then the New York group. I think, yes, that's opportunities for improvement in the administration of neoadjuvant chemotherapy. Now, next slide. Oh, no.